So in 1961, Framingham Heart Study investigators identified serum cholesterol as one of the factors of risk for CAD. Since then, numerous epidemiological and RCTs have established that an elevated LDL is a major contributor for atherosclerotic coronary vascular disease. As a consequence, lipid management has become a central object for prevention of CV events. So we are not thinking now any management of CVD without lipid management. Since 1980s, LDL in CV outcome studies has dropped steadily from more than 150 milligram percent to 69.6 milligram percent and lower in latest combination trials. Now we are looking at less than 30 milligram percent, and this slide shows the journey of decrease in levels of LDL to achieve the CVD targets and decrease morbidity and mortality. Over a period of time, an increasing scientific evidence has led to the journal consensus lower is better goal for LDL cholesterol. It leads to concerns about risk of intensively lowering LDL cholesterol, and there are issues coming up that if we lower the LDL cholesterol, we might find some effects on the body. But evidence today indicates no significant harm, either very low level of LDL or from drugs being used to lower the LDL cholesterol. Aggressive LDL-C lowering is safe and effective therapeutic strategy. That is what the consensus statement is today. Naturally occurring low LDL-C are present in number of population, and virtually all of us was born with LDL-C less than 40 milligram percent, substantiating the fact that if we go lower, we may not find any adverse effect on the body. Lifelong LDL-C levels less than 50 milligram percent have been observed in hunter-gathering societies without evidence of any health risks. No major adverse outcome was associated with genetically inherited conditions with low LDL, while the atherosclerotic cardiovascular disease risk was low in these populations. The treatment approach has changed over a period of 2 decades from high-intensity statin concept to high-intensity lipid-lowering strategy, maybe with statins or without statins. Achieving new goals will require add-on non-statin lipid-lowering therapies like ezetimibe, PCSK9 inhibitors, and bempedoic acid. So, Indian consensus statement by Lipid Association of India, which we generally follow because of Indian data as well as incorporating the foreign guidelines. LAI has adopted international guidelines beneficial for Indians. They have provided flexibility by allowing final decision for the patient to be taken by the physician. That is really, really important. Guidelines are there to guide, and physicians are going to choose accordingly. LAI released a consensus statement in 2016, updated in 2018 and 2020 based on CV risk factor assessment, treatment goals and targets, treatment recommendations, follow-up monitoring, and safety assessments. So India's specific guidelines and challenges are why we are different, that is genetic, phenotypic, cultural, socio-economic variability among Indians as compared to the West, emphasizes need for country-specific recommendations, and still Indians are lacking data, so we are incorporating most of the things from Western guidelines. LAI has proposed lower LDL-C goals for Indian based on recent randomized trials that had shown to further reduce CV risk by non-statin drugs. So these are the risk stratification, what they have given. I will not go into details, but now the risk stratification is low risk, moderate risk, high risk, very high risk, and they have incorporated extremely high risk with category A and category B. So sorry for the poor slide, but this is the newer treatment goals. What is the topic today is summed up in just one slide. The newer treatment goal for statin initiation threshold based on risk categories proposed by the Lipid Association of India in 2020. The high risk group, so I will go short. The risk assessment, the LDL levels vary from less than 30 mg% to less than 100 mg% in low risk group. So the risk assessment varies and the LDL goals also vary according to the risk assessment. So what we are looking at today is less than 30 in very high risk group in category B. So this slide summarizes a lot of things, that is risk stratification, LDL-C targets, management algorithms in stable atherosclerotic cardiovascular disease as well as in heart failure patients. So we go with low risk group, that is LDL if more than 100, lifestyle interventions, still more than 100, add statin. If the target is not achieved in any of the group, we go for the non-statin therapy, that is PCSK9 and the bempedoic acid. So that is the new drug on the board. So similarly, in very high risk group, extremely high risk group in A category, and extremely high group in B category. So we are looking at targets less than 30 mg% to be achieved by combination therapy, as statins will not be able to achieve these targets. So my dear friends, take home message is lipid lowering therapy is key to improving CV outcomes in atherosclerotic cardiovascular disease. Lifestyle interventions in combination with high intensity statin and non-statin therapy are first-line management strategies to achieve LDL-C goals. Change strategy from high-intensity statins concept to high-intensity lipid-lowering strategy is now being followed. But in my personal experience, we must first initiate the high-intensity statins because of its pleiotropic effects. We don't know about the effects other than LDL-C lowering of PCSK9 as well as bempedoic acid. So we must give advantage for high-intensity statin therapy and add-on therapy if we are unable to achieve the targets. So with this, I invite you all to MAPICON 2023 in September at Bathinda. Thank you very much.